Welcome to this video of Pulmonology Read Aloud. I am Dr. Anshu Maneja Arora, and today in Pulmonology Read Aloud, we are diving into the 2026 ERS EULAR Clinical Practice Guidelines for CTD-ILD. Now, as you know, I have a previous video about the ACR ACCP guidelines of 2023, which were two guidelines, one on screening and monitoring of SARD-ILDs and the other which involved treatment. Now, this was just 3 years ago, and with the 2026 guidelines coming up now from the European Respiratory Society, it is liable that you would be confused which one to follow, which one has more up to date information, and what is the difference between the two. So, in this video, I would be discussing both the guideline papers almost simultaneously and trying to give you the latest, the update, and the change. So, let's get down and read this together and try and understand. So, what is the overview and the scope of this paper? So, as I said, the ERS ULAR covers the big five along with SLE. And the big five that were included in the 2023 paper by ACR ACCP included rheumatoid arthritis, systemic sclerosis, idiopathic inflammatory myopathies, mixed connective tissue disease, and Sjogren's disease. So, to add on that, SLE has been included, and this guideline, although does mention SLE, it's important to understand that the task force has not given SLE specific recommendations for screening or baseline risk assessment, because even though they've added SLE, the evidence is not very strong. So that one has to keep in mind. Now, has the methodology changed in any way? Both the EULAR and ACR have utilized the grade methodology, but one major difference here is that this paper also introduces narrative questions to supplement the traditional way in which PICO questions were asked. Now, this becomes really important because a lot of time clinical scenarios are not backed up by good, robust RCT data. So, when you have narrative questions, the task force is able to give you expert guidance on a real world scenario where you actually don't have a high level evidence. So, in that form, the methodology in this paper is better or is an advancement to what was done in 2023. Before I start reading the guideline paper, I just want to mention that lung ultrasound has been mentioned in this paper in the initial screening part. And I'm glad that it is because lung ultrasound is becoming really, really important as part of pulmonology diagnostics. Now, what they have said is that there is a conditional recommendation against using lung ultrasound and replacing it, and they've recommended that you should replace it with HRCT. Now, I know in our part of the world, lung ultrasound is still at its initial stages, but there are a lot of centers where lung ultrasound may be used routinely. But remember that when we're talking about pleura, the specificity is much, much better. But here, when we're talking about ILDs, the reason why lung ultrasound cannot be a part of a routine algorithm is that it lacks that spatial resolution where you can say this is UIP versus NSIP, which you definitely need for treatment in your CTD patients. So, even though you might be able to identify B lines, you might be able to look at acoustic impedance. An ultrasound cannot tell you about fibrosis or ground glassing, so it just cannot distinguish in a connective tissue disease. So while X-ray is not very sensitive in ILDs, CTD-ILDs until it has really advanced, even lung ultrasound, a point of care ultrasound, while it's sensitive, conditionally, the recommendation is please do not use it in place of HRCT. You may use it for added benefits otherwise, but it will not differentiate ILD patterns, and you don't want false negatives or false positive clouding your picture. So now let's address what's really needed. And what's really needed is the high resolution CT scan of the chest. And this is the recommended screening standard. You'll remember from my 2023 discussion that the 2023 paper discussion that there was a conditional recommendation that a high resolution CT scan should be preferred over a standard CT scan and a chest X ray. And the golden rule was that you should try and use both high resolution CT scan and pulmonary function test. Now, the EULAR really tries to reframe that to assert that you cannot rely on PFTs to decide whether you need to order imaging or not. And this goes out to other specialties also, to rheumatologists also, that the guideline very strongly mentions that please do not rely on just a PFT screening. Please perform a high resolution CT scan if you need to screen a patient with connective tissue disease for an interstitial lung disease. It should not be replaced by only PFT. You can do both because we know PFT can miss a large number, rather up to 88% cases, according to some of the sources in the paper. And an HRCT would be a gold standard. So, this is a very strong recommendation against using PFT as primary screening tool, but we know pulmonary function tests are cheap, we know they are fast, we know they are easily available. We are not throwing them out of the monitoring or screening algorithm, but a pulmonary function test cannot surrogate for an HRCT scan. And that's really important information that comes from this paper. Now, the problem, however, is that when we're talking about an HRCT scan, we are talking about so many patients with underlying autoimmune condition, and you just can't put every single patient in a CT scanner. You can't ask them for repeated CT. And I think the guideline paper addresses that issue very well because, again, we are exposing the patient to radiation. So, how they do it is by giving us a list of risk factors in connective tissue disease and rheumatoid arthritis, defining those at-risk patient populations that you must screen for ILD, and in these patient populations, you would ask them to undergo a CT scan. So we are trying to stratify the diseases into very distinct risk tiers, and this is important as we move on with this video, and I'll be showing them again because this is how you can personalize screening. So if I were to read it briefly, when you're looking at a systemic sclerosis patient, the longer the disease duration that he's come to you, if suppose your patient is within the 5-year interval, you would want to ask him to undergo a CT scan to find out if he has a concomitant ILD. If your patient has higher circulating markers, and this includes presence of KL6, which is being used more often nowadays as a screening tool for ILD, a biomarker, and presence of ATA1. And ATA1 is none other than your SCL70. The full form is anti-topoisomerase antibody 1. So anti-topoisomerase antibody, earlier known as SCL70, if that is positive, you must screen your patient with an HRCT chest. And if the patient has a diffuse cutaneous type of systemic sclerosis, and this patient has a higher extrapulmonary involvement, you must screen this patient. Number two, when we're talking about rheumatoid arthritis, something which is a little different from what we perceive. We usually talk about females and rheumatoid arthritis and the risk, but when we are talking about screening a patient for RA-ILD, you must look at older individuals, male sex, and history of smoking. They are high risk factors. You must look at elevated biomarkers like ESR and the presence of anti-CCP and rheumatoid factor. And from my last video also, from the 2023 guidelines also, this was very clear when they mentioned that, when you look at anti-CCP, if the marker anti-CCP is high, there is a direct risk of an ILD in your patient with rheumatoid arthritis. So remember the take home that in such cases, whether you're a rheumatologist or a physician or a pulmonologist, you must look at screening. And higher articular disease activity also will correlate. So, a lot of times there's a conflict between a rheumatologist and a pulmonologist, where the rheumatologist might feel that there's more of involvement of the joints and would be concentrating on treating that, but we would ask for a CT. And now the things are clearer. The guideline has made it clearer. The joint decision says if that is the case, please do screen for ILD. Coming to IIMs, it's important to understand that older the age of the patient, higher the CRP, ESR, and inflammatory markers, and the presence of specific antibodies like anti-Jo1, anti-Rho52, and anti-MDA5 for anti-synthetase syndrome. They are all risk factors for progression. Also, dermatological involvement, such as mechanic hands, is clearly linked to higher risk of ILD. So is the involvement of the joints in the form of arthritis and arthralgia. For Sjogren's disease, older age, male sex, increased CRP again, presence of anti-Rho 52, and presence of extrapulmonary involvement, they are all risk factors. So when you have this list of risk factors, you can stratify amongst the pool of patients where a CT would be definitely essential. So now let's see these two side by side. So this is the algorithm given by this paper for screening of CTDs for ILD. If you look at it, the first year, the one with the green is like the must scan group. So you must scan certain individuals, and these includes those with systemic sclerosis and mixed connective tissue disease. So you must screen all of them with HRCT. What does that mean? Probably you should get a baseline CT scan right at diagnosis for all systemic sclerosis and mixed connective tissue disease patients, and that's period. You have to do a screening with HRCT for all of these. Now, the second section is the ones where there are certain strong recommendations, like here, or there are conditional recommendations, or where it could be based on our clinical practice. So, in IIMs, something that's important is that we have to look at risk factors. And what are the risk factors that we really talked about? Is the presence of these antibodies. These antibodies, along with certain manifestations like the skin involvement. So, the circulating markers like anti-Jo1 and anti-Rho52 will prompt you to do a CT scan. If there are no risk factors, conditional recommendation still says screen with an HRCT after assessing obviously the other risk factors that the patient may have for ILD, which include these. Now, here when we are talking about SSC, again, I would like to make a note that, as I said, SCL70 or now ATA, anti-topoisomerase 1 antibody, may be a specific biomarker where you can classify systemic sclerosis and its risk with ILD. So that will also be included, just like the 2023 ACR guideline. Now, in the rheumatoid arthritis and Sjogren's disease group, again, the risk factors, if they are present, And what are we talking about? The risk factors here? We are talking about anti-CCP levels. We are talking about high articular activity. You may want to screen with HRCT. And if there are no risk factors in this group, then you can look at monitoring and not screening. So it makes total sense that with the prevalence of ILD being so high in systemic sclerosis, and we know that subclinical lung involvement happens in almost all of these patients, you have to be more strict at screening these patients, right? And they do mention that you don't need to blanket screen all of these populations, but you look for these specific demographics, you look for these circulating markers, you look for these biological red flags to trigger an HRCT. And this will trigger a highly personalized risk approach. Just having an autoimmune disease will not be enough. If you have these risk factors, you definitely need to screen. But when you have systemic sclerosis and MCDD, you're not looking for risk factors, you are just screening them for an ILD by doing an HRCT definitely. So we are looking at all the risk factors together and combining our approach. So here, if we are tracing the clinical pathway, the rheumatologist or the physician or the pulmonologist must look at the clinical characteristics like mechanics hand in a patient, look at the circulating markers, order the HRCT, rule out early scarring. And that ways you will be able to achieve a good certainty of diagnosis and ability to manage this patient even without a biopsy. But most of the clinical conditions that we diagnose, we do require biopsies, and the case is a little different here when we are talking about CTD-ILDs. So, so when we talk about CTD-ILDs, the guideline paper discourages us from doing a surgical lung biopsy in all our patients because there is a high risk of morbidity and mortality in this population. And when you combine your HRCT along with the circulating biomarkers, you achieve a very good level of certainty of diagnosis, then you do not need to do a biopsy. So that's something which is very clear. And even for bronchoalveolar lavage, if you're ruling out an opportunistic infection, if you're ruling out alternative diagnosis, you may go ahead and do that. But this advice is very firm that surgical lung biopsy should not be done for diagnosis in CTD patients because we know the tissue is so inflamed and there is remodeling happening. There are pro-fibrotic triggers already. We do not want a catastrophe to happen, and so we should avoid that. So this is the algorithm which gives the workup. So for all CTD-ILDs, the big five and SLE, when you're looking at ILD diagnosis, you confirm your diagnosis, and if there are alternative diagnoses or coexisting conditions that you suspect, that's when you can conditionally go ahead and do a lavage, or you can do other tests to find out the differentials. Now, other than that, you must assess the prognosis, the risk of progression, and whether this patient will have severe disease. So you look at the clinical factors. You do perform pulmonary function testing with DLCO. You look at the HRCT pattern and extent. You do use your 6-minute walk tests and desaturation, ambulatory walking to look at the functional profile of your patients during monitoring. And you also look at another thing which is called as a PROM, a patient reported outcome measure. Now, patient reported measures have gained momentum in this guideline paper, and they talk about how the patient is faring with the disease, what is the patient's perception. Again, there's a note that BAL with microbiology cytology can be used to rule out infection, malignancies, exclude alveolar hemorrhage, but lung biopsy should not have any role in diagnosis unless you have atypical features where you are not clear on your diagnosis. Now, once you're screening, the next is monitoring. And um, even when we looked at the 2023 ACR paper, there was a beautiful algorithm, which I will show you, where monitoring was advised in a particular manner. Now, the broad suggestion by the ERS paper is to repeat pulmonary function testing, which should include the FVC and DLCO, every 3 to 6 months. During the first year of diagnosis of a CTD-ILD, if you're looking at systemic sclerosis, you take it longer for 3 to 5 years. You keep doing it every 3 to 6 months for that long, and then you can do it every 6 to 12 months, right? So, although the 2023 guideline did give us a clue on how we must monitor, it did not specify frequency, and the EULAR is doing that. So, this, which was a part of the 2023 algorithm, this did mention that for IAMs, you would want to monitor the patient every 3 to 6 months in the first year. Then you will do it less frequently once the patient is stable. For SSC, you would monitor every 3 to 6 months for the first year, then do it less frequent, and for the others again. So there was no clear cut demarcation, but the ERS guideline has made this more robust. So this is SSC-ILD. So as I said here, we have to remember that lung function tests for every 3 to 6 months has to be done for the first 3 to 5 years, as against others where you have to do it in the same frequency for the first year of diagnosis. So we follow up more strongly for a longer period. So systemic sclerosis assess the prognosis, risk of progression, and disease severity. And if you think your patient is high risk, then you go ahead and for the first 5 years of diagnosis, tell him that his PFT will be done every 3 to 6 months. His HRCT will be done every year. His 6-minute walk test will be done every time he visits you for within 6 to 12 months. And we will ask him about his patient reported outcomes, his perception of improvement or worsening every 6 to 12 months. Now, if your patient diagnosis has been more than 3 to 5 years, you've already crossed that 5 year mark, say, then you can reduce the frequency to 6 to 12 months from 3 to 6 months. You can still do the HRCT annually. You still need to measure 6-minute walk and patient reported outcomes at least biannually. Now, if your patient has a low risk, even then, because he's a systemic sclerosis patient, our PFT frequency may be 6 to 12 months if it's early onset disease, and every year if it's above 12 months. But HRCT has to be done after 2 years if this patient has a very low risk, and on clinical indication if it's been a long time since he's been at low risk. The 6-minute walk and patient reported outcomes must be measured every year. So he has to come to you at least twice a year to be able to do that, probably because his lung function would be due every 6 to 12 months if it's a relative acute onset of the disease. If there is any indication of progression, however, you must conduct a PFT, an HRCT, a 6-minute walk, oxygen desaturation, look at his outcomes. So the word is that for SSC-ILD, we want to be more aggressive for managing and monitoring our patients. Now, if you look at rheumatoid arthritis related ILD, again, if your patient is a high risk from all those high risk factors and the disease duration has been relatively within the first 2 years, there is still an aggressive way of monitoring every 3 to 6 months for PFT. You can again do the CT scans every year and 6-minute walk and patient reported outcome measures biannually. Only if the disease duration is more than 2 years and he's at high risk, you can delay another 3 months for the PFT, but patient roughly gets a PFT done twice every year. For a low risk patient with a relatively acute onset disease, again do a PFT at least twice a year. If it's more, then at least once a year. And a CT can be done a little longer, so after 2 years, if the risk is low and the duration is less. But nobody stops you from doing any of these if there is an evidence of progression. Coming to IIM-ILD, again here, it's it has to be a little aggressive, just like SSC-ILD. And if the risk of progression is high, then we are doing a PFT every 3 to 6 months for the first 2 years, and a CT scan also. And this I want you to note that here you're also doing a CT scan every 3 to 6 months and every year for the first two within the first 2 years because of the aggressive nature of the disease. It's only after 2 years have passed you can do it every year. Again, 6-minute walk and patient monitoring has to continue at least biannually. He has to come and get and visit you. If he's a low risk case, then the PFT can be delayed another 3 months, and the CT may not be done so frequently but should be done annually. So IIMs and systemic sclerosis ILD, you are a little more aggressive, especially in the first 2 years for in myopathies and first 5 years of systemic sclerosis. Coming to other CTD-ILDs, which includes Sjogren's disease and mixed connective tissue disease, remember for mixed connective tissue disease, a CT scan should be done irrespective of symptoms according to the flow chart given in this guideline. So they mention if your patient is at risk, you do a PFT every 3 to 6 months and an HRCT pattern for at 1 year definitely. Even if he's a low risk, then also you do an HRCT at 1 year. Even if he is more than 1 year of duration of diagnosis, you repeat an HRCT. But the lung functions can be done more frequently in the first year and less frequently thereafter. This is the 2023 ACR chest treatment algorithm, which was a beautiful algorithm, and it was one of a kind because it historically really clarified the use of immunosuppressants. This was the one which laid down um, the way you can choose as first line ILD therapy and additional options. This was the one which gave us a strong recommendation against glucocorticoids and only allowed short term glucocorticoids in all other CTDs except systemic sclerosis, where you have to try and avoid them because of the risk of scleroderma renal crisis. But as you see here, there was always a preference of mycophenolate as the first choice. Yes, you could add azathioprine and rituximab in most other CTDs, but when we're talking about systemic sclerosis, they have mentioned tocilizumab and rituximab as options. They did mention nintedanib, azathioprine, and cyclophosphamide as additional options. And none of these has the mention of nintedanib or antifibrotics at all. Now, this essentially tells us that nintedanib was an additional add-on for systemic sclerosis according to this algorithm, unless the patient had rapidly progressed ILD. But we understand that the fibrotic mechanism and the inflammatory mechanism, the signaling is on all the time. So nintedanib was not, since it's not an immunosuppressant, it was not directly your first choice. What has changed now is that the general treatment strategy has now changed from a preferred and additional to something which is more guided drug selection. So the EULAR are looking at the RCT inclusion criterias of using a drug in a particular CTD-ILD. So they say that if your patient looks like a patient who would have been enrolled in an inbuilt or a census trial and is advancing, is having a decline in lung functions or worsening radiology, that should guide your drug choice. You have to match the clinical phenotype with the evidence available for that phenotype. So this way we are working on both immunosuppression and antifibrotics together. So the current shift here is the combination in severe cases. So, for severe cases now, this guideline paper has made it clear that you can go the tightrope of doing both immunosuppression plus antifibrotic rather than adding it as an additional option. Because the big shift is that if it is already a severe case, you have to hit the patient with a potent immunosuppressant and an antifibrotic together. So, this is the general flowchart of treatment of systemic sclerosis ILD. Just like the 2023, we remember that mycophenolate has been our first line immunosuppressant for choice. So, if there is an ILD with an extrapulmonary involvement or without an extrapulmonary involvement in systemic sclerosis, you definitely have mycophenolate. But this time, there's also very strong recommendation for tocilizumab. So, this comes with a very strong recommendation for a specific systemic sclerosis ILD. So, for early diffuse cutaneous systemic sclerosis, high inflammatory markers, this is the subgroup where, from a conditional status of 2023 guideline, we have moved tocilizumab up. Also, if you see, nintedanib has come into the picture for all patients where the fibrosis extends to more than 10% on the HRCT and no extrapulmonary involvement. So, if you're dealing with SSc-ILD and the fibrosis is more than 10% in HRCT, you should add nintedanib. It is suggested to slow our FVC decline because of fibrosis. So this specifically suggests that if this is the scenario, you can actually upfront combine mycophenolate and nintedanib, or you could do tocilizumab. And this is something which was a point of contention in the 2023 guidelines, but is very clear with this guideline flowchart. Whenever there is a high risk of progression, you give nintedanib and MMF. You can combine immunosuppressants. You can look at cyclophosphamide or rituximab, especially when there is severe multi-organ involvement. You can do that, or you can combine when there is severe multi-organ involvement. If there is no indication of treatment, only then you monitor and make sure your treatment goals are met. But when you have progression, then you have to lift the immunosuppression, you have to make it go up, go higher. Now, whenever there is progression, you add on or switch the therapy. You can, if he was on a mono or a combination treatment, you can switch the immunosuppressant. If it's still progressive, you're seeing fibrosis more than 10% and nintedanib. Um, so far, biologics are not being asked for in combinations, but that may happen in the future. You must look at the lung transplant, whether you need to refer this patient, and remember in systemic sclerosis, avoid high dose glucocorticoids. For rheumatoid arthritis, the focus is on broad immunosuppressant management. And here again, although mycophenolate and azathioprine still exist, you'll see that the usual clinical practice of tocilizumab and glucocorticoids is also added, with a conditional recommendation giving a lot of emphasis on JAK inhibitors. So, rituximab, JAK inhibitors, and abatacept have been a good conditional recommendation. So, you have more choices, but you have a good recommendation. Now, we must be cautious with certain biologics like TNF alpha inhibitors, especially if the ILD is progressing. But in case you need to treat both the joints and the lungs simultaneously, they do mention that the role of rituximab is very high. For a patient with a good controlled arthritis, the rheumatologist is happy, but you are not with the ILD, then you must combine immunosuppressants. You must add nintedanib or combine immunosuppressant and nintedanib. And if there is a UIP pattern, there's a specific indication where pirfenidone can be used. Also, in progressive pulmonary fibrosis, you can use pirfenidone. So, specific to rheumatoid arthritis, the EULAR suggests pirfenidone for patients exhibiting a UIP pattern on an HRCT. This is again a very clear first line consensus for pirfenidone, which was faintly mentioned in 2023 guideline, but now it's made very, very clear. Again, if the progression is there, the goals are not being met, you may have to add or switch therapy. You may have to, you will have to add an antifibrotic. Again, biologics in combination, not much evidence. Consider referral for lung transplant. And here also avoid long term high dose glucocorticoids and consider more of steroid sparing treatments. For IIM-ILDs, any IIM-ILD, immunosuppressive treatment is the choice. Remember, we need to be very aggressive. We may require a multi-drug approach. We have a very strong recommendation for combining immunosuppression. We have a very good recommendation for even including glucocorticoids, including calcineurin inhibitors and rituximab in IIMs. There is also mycophenolate and azathioprine as in the 2023 guideline. But the CNIs, the rituximab and glucocorticoids have been the strong recommendation. We need to be very aggressive in managing. We need prompt induction as a priority to prevent a rapid irreversible loss of lung function. If there is high risk of progression, the combination with high dose steroids can be done. There's also some role of IVIG. There's progressive fibrosis. You would be adding nintedanib with the immunosuppressions. And rapidly progressive ILD, we try whatever we can with IVIGs, with immunosuppressants, with plasmapheresis as well. So be very aggressive when you diagnose an IIM. Again, if it's progressing from mono, make it combination, switch the immunosuppressants, give the antifibrotics, and give steroid sparing treatment for long term. For other CTD-ILDs like Sjogren's, MCTD, and SLE, here again the pooled evidence has been given. We've always started with mycophenolate azathioprine as the immunosuppressive treatment coming from 2023 guideline. Here the key is to early identify and aggressively manage extrapulmonary involvement also with the ILD. You may need glucocorticoids, you may need rituximab and cyclophosphamide, especially if there's multi organ involvement. You may need a combination, and you may need an antifibrotics along with immunosuppression. So in other CTD-ILDs also, the key is early identification and management. With that, combination therapy, upfront or sequential, this has been a major point of divergence from 2023 guidelines. The 2023 guidelines were more conservative. They conditionally recommended that do not do upfront combination of antifibrotics with MMF as a first line. But the ERS EULAR are more permissive of the upfront combination therapy when you're dealing with high risk patients and those with progressive pulmonary fibrosis. So, EULAR is a little more permissive, and you can do that when you know your patient is going to worsen. For glucocorticoids, a vital safety reminder is that both the guidelines are strongly recommending against high dose or long term glucocorticoids, especially in systemic sclerosis because of the risk of renal crisis. But when you look at IIM, steroids are a critical cornerstone of the induction protocols, and so they are allowing that to be included. So these are the risk factors for poor outcomes or disease progression and death. And if you look at systemic sclerosis, they've added, in addition to older age and male sex, African American ethnicity, the anti-topoisomerase levels, the baseline PFTs, more ILD, and rapid skin involvement and more extensive skin fibrosis. For rheumatoid arthritis, the titers are important, the HRCT is important, the extent of involvement and articular disease involvement. And in IAMs, specific levels like elevated ferritin, which can be very useful clinically, anti-NMDA5 presence, anti-synthetase presence, and higher extent of ILD. These are all several risk factors that will predict that this patient is going to have a higher risk of progression, and you can do upfront double or triple immunosuppression. For MRSS, it's a modified Rodnan skin score, which is a score for the skin involvement in systemic sclerosis. Now, progressive pulmonary fibrosis, this term has been embraced by EULAR, and they say that if your patient meets the criteria for PPF, like in the inbuilt trial, like a combination of declining FVC more than 10% of relative, worsening symptoms, or increasing fibrosis on CT, the typical inbuilt inclusion criteria, if your patient is meeting that criteria, you can do a combination of immunosuppression and antifibrotic. Lastly, rapidly progressive ILD. This is the 2023 flowchart where they said that if it's rapidly progressive, do not be conservative. You add or you switch therapy. If it's systemic sclerosis, again, strongly don't try long-term glucocorticoids. Give mycophenolate, rituximab, add antifibrotics, give cyclophosphamide if required. If you have to look at hematopoietic stem cell transplant, that can be done as a referral. So that all can be done. If it's myositis, then yes, the calcineurin inhibitors, the JAK inhibitors, they are all a part of the picture, but you have to basically add or switch therapy amongst all the options that are available. You can aggressively give triple therapy like pulse steroids, cyclophosphamide, rituximab, or calcineurin inhibitors immediately in a rapidly progressive ILD. You don't need to wait for a stepwise approach and a lung transplant referral, especially when you're looking at IIMs with anti-MDA5. You have to be aggressive right from the start. And what EULAR has done is it's integrated all of these values, and it has focused on increasing up the hierarchy of management, but it has integrated the RP-ILD management directly into the IIM flowchart and other CTD flowchart, favoring aggressive combination induction. So it's been included in the flowcharts, and a separate flowchart for this has not been provided in this guideline. With that, the last section, the future, it's mentioned in one of the tables, and this is really intriguing and exciting of what they have mentioned as a future. They mention about the use of AI in predicting disease trajectory. They've mentioned how MUC5B genetic variants can be targeted. They've mentioned about liquid biopsies where blood draws can help us find fibrotic biomarkers instead of doing a lung biopsy. They've mentioned about CAR T cell therapy where you reprogram your own T cells as guided missiles to target the agents, the cells which are causing fibrosis. And they've talked about wearable biosensors to track lung function and oxygen in real time. And that's really exciting arena of the future of these ILDs. So with that, I close this video, and I would like to summarize that according to the ERS and EULAR recommendation, it's important to screen rapidly progressive or aggressive ILDs with an HRCT. Do not be blinded by just a simple X-ray or just a PFT. One screen, be aggressive in monitoring for certain types like systemic sclerosis, the ones with anti-topoisomerase positive, and the IIMs, and be wary of the risk factors of others. Treat with immunosuppression actively. Monitor these patients with at least an annual HRCT and look for those subtypes which may rapidly progress. So with that, I would conclude this video. Please do like, subscribe, and share Pulmonology Read Aloud. Thank you and have a good day.